As of this morning, Strong Memorial Hospital was caring for 57 patients who have tested positive for COVID-19. 31 of those patients are in an intensive care unit at Strong, and 26 are in standard patient rooms that have been designated for COVID care. Because there is not yet a medically proven treatment for COVID-19, the public has many questions about how hospitals treat patients who are seriously ill with this disease. We're pleased today to be joined by two doctors from the URMC Department of Medicine who can answer those questions. Dr. Justin Hopkin on the left is Chief of Hospital Medicine at Strong, and on the right, Dr. Paritosh Prasad is Chief of the Highly Infectious Diseases Division and the Surgical Intensive Care Unit. Together, these two lead the teams of providers at Strong who care for COVID patients. I want to thank them for taking the time to join us today. And now we'll begin taking your questions. And first up, we have Patty Singer from Minority Reporter.
Wow, leading off. Thank you. But there'd be a
first in line, Patty.
Oh, I tell you, lead off hitter. What has been your biggest challenge with information changing every single day about protocols? What's been your biggest challenge in trying to establish at least a protocol for the UR or Strong, getting some consistency in treating patients?
So it's an excellent question, because it kind of gets to the heart of one of the great difficulties in dealing with the pandemic. It's the information is changing on a daily basis. The volume of patients and everything that we're facing is changing on an hour-to-hour basis. Our greatest challenge has been trying to keep up with those changes and to communicate as we consolidate around a plan, working as a team, how we communicate that across an enterprise as large as our hospital and the hospitals we all work together with. And we've been really fortunate with our staff and our colleagues, our nurses, our physicians, all the people across the institution. We've been able to communicate not only our plans as we make them, but also we've had the flexibility, and our colleagues have had the flexibility of being able to roll with punches as things change on an almost hour-to-hour, day-to-day basis.
So can you outline, is there a protocol? Can you outline the triage that you do for someone who would be in a regular medical surgical bed versus when they come into the ICU versus when they need a vent?
Sure. Why don't we start with the medical floor?
Yeah, I think as far as general communication goes across the enterprise, our daily incident command meetings are where we really establish the tone for the day. And we're able to communicate with the various hospitals and leaders in those hospitals about any significant changes. And then it comes to leaders like Tosh and I to get the communication out to the members of our team to really develop a plan for the day moving forward. And I think communication in that sense has gone really well and enabled our teams to function at a pretty high level. When we're looking at patients, when they're coming into the hospital with COVID, the emergency department is doing that initial evaluation, and it's not that much different than a patient that we would usually take care of here in the hospital. We do an assessment of vital signs, and as we teach younger doctors and medical students, our first assessment when we walk in the room is this patient sick or not sick? And many times, within 30 seconds, a seasoned clinician can tell if this patient is medically stable and will likely be able to come to the floor, or if they're having trouble breathing, appear very unwell, and will go to the ICU. And after a workup that our emergency room physicians are able to do pretty rapidly, they're able to triage those patients usually in one of two directions, either admitting to the medical floor for the level of care that we would provide, or if someone is sicker, if they appear to be in respiratory distress when it's COVID, if they're requiring more oxygen than we're able to deliver in a standard medical bed, then those patients are triaged to the ICU.
So exactly as Dr. Hoffman pointed out and Justin pointed out, that a lot of the decision around the need to move to the intensive care environment is pretty much driven by the level of support a person needs, the amount of oxygen that they need to keep their breathing stable and their oxygen levels adequate, as well as we've seen with this virus, it not only can affect your breathing and your oxygen levels, but in some cases it can affect your blood pressure as well. And so we look at those different parameters, and when a person needs that level of support, we can very rapidly get them down into the highly infectious disease unit, which is essentially our intensive care environment for patients with COVID. And there we can provide that higher level of oxygen support or blood pressure support as needed. And as you asked about a protocol, we have a number of clinical leaders throughout the institution that represent all the different divisions, all the different groups that work in critical care, from medicine, surgery, all across the board. And we've worked together to try and develop exactly how we support, from increasing amounts of oxygen to some of the higher levels of oxygen we can provide, to when a person needs to go on a breathing machine. The decision to go on a breathing machine, a ventilator, is very much driven by once the person is beginning to tire out and they're not able to do the work of breathing on their own.
Thank you, Patty. Next, Sean Lehman from the Democrat and Chronicle, and after that, WROC TV Channel 8. Sean? You're unmuted, Sean. Do you need to six?
I'm good, thanks. With regards to patients who are going into that, either into the medical situation or the intensive care situation, we've been through a few weeks of this now. Can you give me a sense for what level of distress you're typically seeing, and how long patients are spending in either of those settings before they're able to leave?
Yeah, I think what Tosh and I have observed is that patients can come in looking rather well, and often it's around 4 or 5 days of illness where patients have had fevers, they've had the shortness of breath for a while. It's often later in the disease course when we see that they are starting to require more oxygen, or that they're having a more difficult time breathing. And we've created a mechanism when we're starting to notice that the oxygen requirement is going up, or that the work of breathing is worsening, where we have a quick transfer to the ICU for closer evaluation, probably more so than we usually would, just recognizing that these patients, when they do tire out, they do much better once they are on a ventilator machine. And that progress between feeling relatively well and doing relatively well and getting pretty sick requiring a ventilator is shorter than other diseases that we typically deal with. And so our trigger to get patients to the highly infectious disease unit is very short, and that's one process that I think we've done a good job of getting those patients stabilized quickly and not delaying those transfers to the highly infectious disease unit.
And one really important thing about this virus is that the grand total experience that our profession as physicians and our nurses all together have with this disease is no more than about 2 to 3 months. And so we've really approached it with a profound level of respect and the recognition that we are learning about how best to care for our patients with this disease process essentially on a daily basis. And so really that close communication between our services and making sure that we can move rapidly and really respond to what each other is seeing has been the sort of the central point of how we take care of our patients.
Sean, did you have a follow-up question?
Sure, a quick follow-up. I think the popular perception is that the folks who are getting into serious trouble with this disease are folks who are older, have some existing conditions. Can you say whether or not that perception is true based on what you've seen?
By and large, that is very true. This is a disease process that for the vast majority of individuals who will develop COVID-19, they have fairly mild symptoms, if no symptoms at all. It's a small percentage that will develop symptoms enough or severe enough that prompt them to not only seek care and evaluation, but that would actually require hospitalization. And then a smaller subset of those folks who require hospitalization who end up requiring a higher level in the intensive care unit, or a higher level of support in the intensive care unit. And by and large, it's the extremes of age and the existence of other medical comorbidities, other medical problems that pretty much define the vast majority of folks who require those higher level of care.
Thank you, Sean. Next.
Thank you.
We're gonna unmute Rory Felicia at WROC Channel 8.
Hi, it's actually Rebecca Fast. How are you?
Oh, hey, Rebecca.
Hi, how are you guys doing up there? First question, doctors. How are you holding up?
We're doing great. Thanks for asking.
Absolutely.
Great. Now, kind of going back to the question of this being relatively new, you know, and we've learned about where we stand now with how we're sort of learning as we go, getting people into the right situation. What is kind of the most shocking thing as to date of what you feel like you've noticed about this virus? What kind of stands out as being so powerful and unique just as of today?
Yeah, I think really with open access, we learned from other institutions sort of what to expect as far as what presentation these patients would have, as far as their difficulty breathing, their fevers, how long they may be sick, how long they may be intubated. One thing that I think has surprised Tosh and I is the ratio of the patients that have required the intensive care setting versus the patients that we've been able to manage on the medical floor. We expected that about 2/3 to 3/4 of our patients would be able to be managed on a general medical surgical floor, and the rest being in the ICU. And so far, it's been more ICU patients than we anticipated. I think that could be for a couple of reasons. One might be the excellent care that our outpatient physicians are providing in being able to manage some of these patients outside the hospital. And that's probably the best explanation I have for that right now. But that would be, I guess, one thing if I was surprised by anything, it's sort of the mix of patients, critical care versus not critical care.
Certainly, you have the opportunity of side by side seeing it. It's not very common that you have one type of illness in patient after patient after patient. We're pretty used to having a mixture of patients with different disease processes. And what's so, when it stands out is when you have a unit full of 30 or 40 patients who all have the same disease, seeing that even within the same disease, there are patterns, there are sort of different, in our term, phenotypes, that it is a different virus and it acts differently than things that we've seen before. It has the same effect on the lungs in some ways, but then in other ways, the way that we expect people to behave on a ventilator, it's a new disease. So we're learning as we go. But one important piece to kind of come back to, even though there's proven treatment for COVID-19, it's really important to know that the way that the virus affects the body and the way that people get into trouble, we have very well developed proven treatments of how to support patients in those settings when patients have respiratory failure, when their blood pressures are low. And what we've learned from our colleagues across not only the country, but across the world, is that if we do the things we know how to do, that for the vast majority of folks, that will get them through this. It takes time, and it takes a lot of patience and a lot of fortitude from our patients and their families, but we can get them through this.
Wonderful. Thank you so much.
Yeah, I might just add, I think the ability for all levels of people caring for these patients to rapidly adapt and really practice at a very high level has been something that maybe even I'm surprised at, to see our nurses have the ability to adapt to entirely new disease and a different process of how we take care of patients with the donning and doffing and the PPE. To have our physical therapists adapting to those same circumstances in a different patient population, to have our pharmacists in the game helping us figure out medications that we should be giving and doses. It's really been a team effort, and everybody really got up to speed at a very rapid pace. And I think that's been a big help for us and other people involved in these patients' care.
They continue, whether it's our nurses, our physical therapists, our environmental service workers, whether it's our pharmacists. Each group individually is taking the lead on their aspect of how to care for these patients, and they're pushing everything forward. They're keeping pace with it at a level that no individual group would be able to do by themselves.
Wow, thank you so much.
Thank you, Rebecca. Next, we're going to go to Raven at WHEC Channel 10, and after that, Wendy Wright at Spectrum News.
Hey, so my question is regarding the ventilators. How do you guys determine, who and when one is needed? And are you guys seeing ventilators more for the patients in intensive care, or is it for really, it just determines person by person?
So there's not a lot different about how we use the ventilators and how we determine who needs a ventilator with this illness compared to other respiratory illnesses and other reasons that somebody like the ventilator in the intensive care unit. The ventilator essentially helps a person breathe and helps them get oxygen into their blood and carbon dioxide out. So when we evaluate a patient, we're looking to see how well can the person sustain that work of breathing on their own, and how well are they able to get oxygen in, which is what we can measure with looking at their oxygen saturation. There's no difference really from that compared to with other illnesses that we're used to. So we've got fairly standard criteria that are not only based on some numbers, but also, as Justin pointed out, an experienced clinician, an experienced nurse looking at a patient, we can tell when someone's in distress, and we have a sense of the trajectory when we really need to get in and help support that person, because we're worried that they can't sustain it on their own. We haven't had any issues as far as availability of the ventilators. And so really it's anybody who needs one, we can get you on to get people supported.
Raven, did you have a follow-up question?
Yeah, and how are you guys working to just protect other patients and the staff from keeping it from spreading?
So we've had the benefit of an absolutely incredible infection prevention group that's been working closely with all levels of staff throughout the enterprise and with our leadership to really ensure that from the get-go, we not only understood how the virus spread, but that we were able to communicate that in a way that everyone could really incorporate into their daily work. This is a virus that primarily transmits through droplet and contact, so in the little droplets of when people sneeze or cough. And so the really important focus on ensuring everyone's washing their hands, that we're using the appropriate personal protective equipment, making sure that's available for everyone, identifying specific situations in which that virus might be able to get into the air, and ensuring we have the right types of masks for those environments. That's been a central focus of our infection prevention group, and they've been working hand in glove with all of the people on the front line to ensure that not only do we understand the science of how this thing transmits, but how do we put that into real world practice to make sure that everybody involved in making sure our patients are safe can stay safe themselves, and also minimize the risk that it spreads anywhere beyond.
I would give some credit to the supply chain team here at the hospital. From day one, they've been incredible at being able to make sure that every person who walks into the hospital has the protective equipment that they need to feel safe in doing their job, whether it be the person who greets you while you're walking through the door, the environmental service person who is cleaning the rooms and keeping the hospital sanitary, or whether it be the providers that are at the bedside. We've had masks, we've had gloves. Our orthopedics, our prosthetics and orthotics department actually made us our own face shields to help preserve our masks and decrease our risk of exposure when we're having patient-facing contact. And so it's all those things that have helped ensure that the providers are safe, also keep patients safe on the other side, whether or not they have symptoms of COVID or not. We're practicing the same meticulous hand hygiene and doing the same things on all of our units to prevent the spread of disease between providers and patients, patients to providers, and then staff within the hospital.
The other group that I really think we should, we have to say thank you to, and we do on a regular basis, is our laboratory.
Yeah.
We have been profoundly fortunate through not only the incredibly tireless efforts of our lab, but of the incredible leadership that our lab directors have shown. We've had the opportunity and the benefit of having the availability of testing for COVID-19. Not only from the beginning, but really they've been able to raise up the level of testing that we have to ensure that any patient that's coming into the hospital and now outside of the hospital that we need to be able to evaluate to make decisions on how to care for them and how to help protect them within the hospital and other patients within the hospital. That has been something that, despite all the shortages around the state and the country, our lab leadership has been thoughtful in how they've approached this, and they've been able to stay one step ahead, and that's made all of our jobs it's made our jobs feasible, honestly.
Thank you, doctors. Next, we're going to go to Wendy Wright at Spectrum News, followed by Jane Chaco at 13 WAM TV. Wendy?
Hi, thank you. Can you hear me okay?
We can hear you, Wendy.
Okay. I had a question about the specific treatments, the drugs that have been administered to the COVID positive patients. the hydroxychloroquine, the remdesivir, and have you given anybody their convalescent plasma to this point?
So we haven't used convalescent plasma yet. That's a therapy that's still being evaluated on a number of different levels. All of the treatments that you've described, the hydroxychloroquine, remdesivir, another drug called tocilizumab, and then convalescent plasma, all of these therapies are still experimental. And one of the things that we are very aware of is, as much as we want to have the availability to provide the best treatments possible for all of our patients, any experimental therapy, by definition, we don't know that the benefit outweighs the risk of the treatment. Convalescent plasma is one of those therapies where we have to be really thoughtful about the potential risk as well as the benefit. We're pretty used to using virus-specific antibody therapies. It's actually something that we use for a number of different viruses prior to COVID-19, and generally in our immunocompromised patients. And one of the things we know is that while it can be very effective, it's essentially arming the immune system against a virus. And while that sounds like a really good thing to do, and it is in many cases, one of the things that we've experienced with COVID-19 in particular is that a lot of the consequences for the patient, what makes them so sick, is actually their own immune reaction to the virus. And what we've seen when we've used virus-specific antibody in other situations prior to this, not just ourselves, but sort of nationally, internationally, is that when you arm the immune system, you can get a lot of inflammation as a consequence of that therapy. In somebody who doesn't have an immune response, that's very helpful. But if the majority of what you're seeing, the consequence the patient's experiencing is due to the immune system, if we give that therapy, we can make things a lot worse. So we're trying to be very, very thoughtful and working closely, not only with our own scientific leadership here, but with institutions across the country to really understand how best we deploy this therapy, not only to understand is it beneficial, but to do it safely, because we don't have defined proof that it really helps people yet.
And I think we all want a treatment that really works. We want a pill that we can give a patient and know that it's going to improve mortality, that it's going to shorten their hospital stay, and that will help treat COVID-19. And what we have to be careful of is pushing through data too quickly before we have the gold standard, we say randomized placebo-controlled trial, to really show that these therapies are likely to work. And there is some data that is out there that is showing that these treatments that we're studying may have some effect on COVID. But what we want to be careful of is that we don't use our own biases to either set these trials up so they look like they may work when they really don't, or we interpret data that really isn't designed to prove that just one therapy is helping these patients. And what we really need to know is if we gave a patient a therapy, did that therapy really help change the course of the disease if we hadn't given the therapy at all? And that's really the placebo. What we don't know is how these patients would do with or without if we don't have a placebo group involved in these trials. And so our Clinical and Translational Science Institute, once we saw this disease coming, has been very active in identifying appropriate clinical trials that we can be a part of. And so they are looking at medications like Plaquenil. We're part of the remdesivir trial, but we're being very thoughtful about the trials that we participate in. And what we know is that placebo-controlled trials are more likely to offer more information to the greater medical community so we can make a decision on these therapies. And so we're partnering with other institutions to be part of larger clinical trials so we can study Plaquenil in the inpatient and the outpatient setting. And we're already part of the remdesivir trial, and we're looking at other therapies that may be useful. And so we appreciate their guidance, their leadership, and partnering to try and make the use of these therapies not only helpful for the patients that we're potentially treating, but contribute to the greater medical good and understanding if these therapies are going to be effective.
Thanks, Dr. Hopkins. Wendy, did you have a follow-up question?
Yeah, we've been talking a lot about the situation in the nursing homes. Can you explain from your standpoint at what point you take a positive patient from the nursing home to the hospital, and then at what point you think it's safe for them to be returned to the nursing home, and how that's actually done? there's been concern about as you know, the COVID patients inside the nursing homes and separating them, and if the nursing homes have the proper facilities to keep them isolated.
Yeah, I think our nursing homes were also involved in the command center meetings from a very early stage. They recognize that many of the patients that live in nursing homes are the patients that have the greatest risk of morbidity associated with COVID. And so they were preparing in a variety of ways, looking at having units where they could potentially quarantine some of their residents that may have signs or symptoms of the disease, but also making sure they talked with their patients and making sure they understood what their patients' wishes were should the event they develop an illness that may require hospitalization. And there are some patients that may say, if I got sick enough, that's not something that I would be interested in, versus others that would say, yes, I would want to go to the hospital. And so that's the first step. Once a patient's vital signs are abnormal, once they start to require oxygen, that's when the nursing home would make that decision to get in touch with the hospital and transfer that patient to be evaluated for care here in the hospital. Once they're here, there's been recommendations based on the county as far as testing of patients before they return back to the nursing home. So we've developed a protocol where we're working with each of our healthcare facilities where we do testing on patients before they return back, so they can know if that patient is actively shedding virus or has COVID at that time or not. And that helps in their ability to quarantine patients.
And just, I know we only get 2 questions, but to follow up just on what you said,
Sure.
The end of life part of it is, so if they have chosen, say, not to be ventilated, should it come to that, would they stay at the nursing home or come to the hospital?
There's a lot of different approaches on that front, and we have a phenomenal palliative care group that's been working not only inpatient, but also working very closely with the nursing homes in the outpatient realm to help address exactly the needs and desires of the individual patients. It's very much a discussion around what a person wants, how they, if one is looking at sort of significant illness, what are the things that are of greatest priority? What are the things that are most important to a person? For some folks, that is doing everything we can to try and get them through, recognizing that the quality of the time that we're going to create may not be very good, but it may eventually get them back to a better quality of life. For some other individuals, depending on both their beliefs as well as the state of their illness, it may well be that the things that medical science needs to do to help them prolong the time that they have going to result in a quality of life that that individual person deems unacceptable. And that's where our colleagues in palliative care and all of us work together to really identify what are the values of that individual and how do we meet those values. If what defines someone's quality of life is staying in the living environment that they're in, we'll do everything we can to try and achieve that in a way in which they can be comfortable and have peace and dignity in the time that they have. Sometimes that involves staying at the nursing home. Sometimes that involves coming into the hospital and to our hospice unit. So it really is a very individual situation, and one that's discussed between the individual, the person, the provider, and their providers, the palliative care group, the physicians, the nurses, etc.
And we should be clear.
Thank you.
Wendy, we take patients from all nursing homes, but Dr. Hopkins, you were talking about UR Medicine nursing homes at first, and they have not yet had a positive COVID case.
Okay, great. Thank you for clarifying.
Thank you. We've got Jane Chaco at 13 WAM, then Will Astor from Rochester Beacon. If there's any other reporter on the line who wants to ask a question, please use the chat and let us know you're there. Jane?
Hi, yes. What is the percentage of people on ventilators that survive?
So right now we're doing our best to kind of keep track of how many patients are coming through. Most of our patients right now are still those that have been on ventilators. Many of them are still on ventilators. A significant portion, probably around 30% that started out on the machines, have actually gotten well enough to come off the breathing machines. A significant proportion that started are that came in sick are still on treatment with the ventilators. Looking at the number of folks that have passed away, It's about similar to what we've seen across other institutions, and particularly with the disease condition they have, not COVID-19 per se, but ARDS, which is the severe inflammation of the lungs. So it is certainly nothing like some of what's been out in the media and in the public sphere, worry that if a person gets on a breathing machine, there's no chance that they can get better. That's not been our experience at all. The vast majority of individuals who do require support on a breathing machine will be able to liberate from that machine. What we have found is that it does take longer than what we've seen in other illnesses in general. So most patients need an average support of somewhere on the order of 10 to 14 days on the breathing machines, which makes it a kind of a hard sense to give you a number of what is the absolute mortality rate, because this has really been going on for about 2.5 months. Many of the patients are either still on support or just liberated from support. So we're evaluating as we go, and we're keeping track of those numbers. But right now, we're not seeing any higher signal of mortality than other centers have seen that have not been overwhelmed. But we have been fortunate that our resources have been able to meet the need.
And Jane, before your follow-up, I will risk embarrassing myself in front of Dr. Prasad. When he said ARDS, that is acute respiratory distress syndrome, and that's the disease that we've been treating commonly for decades that COVID causes. Is that right?
That's exactly correct. And when I say that, we don't have a defined treatment as far as a drug goes, but we know how to treat this disease. The way that ARDS, or the way that COVID-19 makes patients really, really sick, is by causing inflammation in the lungs. That is this condition called acute respiratory distress syndrome. And we have known since 1999, multi-center randomized controlled trials is sort of the gold standard of how we know how to take care of patients. We've known since 1999 how to take care of this illness, and that knowledge has been evolving and getting better as we go. So there are things we can do. It's just not, we don't know of a pill yet that fixes this, but we know what to do in the intensive care units and on the hospital floors to help support patients through it.
Yeah, and one thing I might add is when that 10 to 14 days of intubation is done and Dr. Prasad's team's able to effectively remove the breathing tube and take them off the ventilator, that person is not back to where they were 2 weeks before they came in the hospital. They're really deconditioned from the prolonged illness. So we're talking about 10 to 14 days on the ventilator, but we're also talking some time before patients are getting up. They're working a lot with physical therapy. They're trying to get stronger. They're trying to work on their nutrition, things like that. So it's a longer road, and we have a lot of supportive services that are helping patients through that, recognizing that they may need to transition to get rehab, to get their strength back, and before they're able to go back to the community. But again, we're relatively new at this. We're not even a month in, and so starting to see some of these patients who are coming off the ventilator, coming to the medical floors, and even being discharged out of the hospital. They've been good wins for the team, and it's good to see those patients, and we hope to have a lot more of them.
Mm-hmm. You have a follow-up?
Yes. So we've heard, and it's out across the internet, that ventilators are the last resort for some patients. Is that true? And are there any alternatives in terms of breathing machines or others to vents?
I'll let the critical care doc answer that.
So, as I said, we use the ventilators to primarily support the body's ability to get oxygen in and carbon dioxide out. Up to the point of needing a ventilator, we have a number of other support mechanisms that we can use, number of different machines that can help get oxygen into patients and get carbon dioxide out. One of the limitations that is probably fairly heard a lot about in the internet is that a lot of the non-invasive supports we have, people use the CPAP machines at home or a BiPAP machine, or even the high oxygen level supports that we use. A lot of those, there have been concerns have been raised about if we use them, could they spread the virus? We have been incredibly fortunate because with the expertise of our clinical engineering group, all of our ICU rooms, all of the critical care rooms that we use for taking care of patients with COVID-19, all of them have the ability to create what's called negative pressure. So even the slightest amount of aerosol produced by this virus, which is why those other treatments they worry about using them because you could spread virus if it gets into the air. every one of our patients with COVID-19 who's in the intensive care unit is in a room in which the air is essentially not allowed out of that patient's room. It's purified so that it does not expose anyone else. That gives me and my critical care team and our nurses and everyone the ability to use the full scale of our treatments, the CPAP, the BiPAP. So there's lots of steps we can use up to needing intubation. As you said, it is our final resort. If a person does not tolerate or we cannot get oxygen into somebody even with intubation, there are a few other things that we can do. One of the ones that's been used prior to COVID-19 in these situations is a full heart-lung bypass, which is called ECMO, or extracorporeal membrane oxygenation. That's something we have as a treatment we are able to use in patients who are failing treatment for ARDS. It has not been a treatment that's actually been very effective in the context of COVID-19 for reasons for how the virus makes your blood kind of thick. It makes it, you have a higher risk of blood clot when you have this virus. And so that therapy is an option, but it's not one that's been used very often. In fact, once we're patients on the ventilator, we have techniques that allow us to really get oxygen in, allow people to get through the illness. And so we've been fairly successful when we do have to resort to that final resort, which is the ventilator.
Thank you.
Thank you, Jane. And last but absolutely not least, Will Astor from Rochester Beacon. You have a question, Will?
Yes. There was a column in the New York Times this morning by Dr. Richard Levitin, I guess, who is a noted airway expert, talking about his experience at Bellevue treating COVID-19 patients. And he talked about a peculiarity of COVID pneumonia, which is, I guess, silent hypoxia, in which the patient suffers significant oxygen deprivation, but doesn't notice it until very late in the game. Does this affect, or should it affect evaluation, how soon people come in, how soon you treat them, and what kind of evaluation you do?
Yeah, that's a great question and a good point to bring up. What's COVID versus COVID pneumonia? In looking at studies that have been done on other populations where general community members have been infected with this disease, we think there's a fair number who are able to get by without the use of oxygen. They may have an influenza-like illness where they experience muscle aches, fevers, cough, generalized fatigue, and maybe some other symptoms as well. And for the most part, most people don't have to be hospitalized for those symptoms. There is a group of patients that we're taking care of here in the hospital that do require what we would say is a higher level of care in a hospitalized state. And usually that's because of a need of oxygen. So we do an evaluation in the emergency room that involves lab testing and chest x-ray. And what we're finding is that many of the patients that do require oxygen and have COVID have evidence of abnormalities on their chest x-ray. And by definition, when we see abnormalities on a chest x-ray and infectious-like symptoms, we call that pneumonia. There are different organisms and different things that can cause pneumonia. Dr. Prasad and I often take care of patients that have bacterial pneumonia, and we know that antibiotics are helpful for bacterial pneumonia, but there are viruses that cause pneumonia as well, COVID being one of them. And so the patients that we're talking about that need oxygen and that have COVID, by definition, really have pneumonia secondary to COVID. And so that is the group that we're talking about. Not everyone that has COVID will get pneumonia, but those that have higher oxygen requirements generally will have findings on the x-ray, and we diagnose them with pneumonia.
One of the things in regards to the surprising degree of hypoxia, the low oxygen level, it's absolutely true that we do see that, and our patients tend not to be as symptomatic when their oxygen levels are low. But I think it's really important to point out, and I think one of the concerns that I think a lot of folks have when they hear that is, oh, could I possibly have this terrible infection and could I be really sick but not know it? And I think that's really important to clarify. While it's true that the level of oxygen is surprisingly low for the amount of distress the person has, the person is still in distress. They feel sick. they feel like they cannot breathe or they're coughing. It may not be as severe as one would expect given how low the oxygen is. So certainly if you do have symptoms, if you feel sick and you're having respiratory symptoms, it's really important to talk to your provider and to be evaluated either by the telemedicine approaches that are available or to be in touch with them. But it's not something, and this is what we want to make sure nobody feels, that you could just be walking around feeling like you regularly feel, and in fact, you could have a terrible process in your lung at the same time with COVID-19. You're going to feel symptoms of this illness if you're having that low level of oxygen. It's just that it seems a little out of proportion, but it's not a silent hypoxia in the sense that the person is completely asymptomatic, but also with this incredibly low oxygen level.
And before your last question, Will, I should say people that don't have a provider but do feel at all symptomatic should call the 888 number on our URMC website, the COVID website, and then our urgent cares can take a look at them, give them a test if they need it, and make sure they get the care they need. And Will, I think the last question for the day is you.
Okay, thanks. Well, thank you, Dr. Prasad, for that last comment, because when I read that column, that's exactly what I thought. The other thing that he noticed in that was that a lot of patients who presented at Bellevue for it to the ER for non-COVID things turned out on examination to have COVID pneumonia. Is that something that you're noticing here?
It's hard to say that a lot of patients, so it's absolutely true that a significant proportion of individuals who develop COVID infection with COVID have mild symptoms. And so certainly we have to be very thoughtful and on the watch for when a patient presents with other symptoms or other medical issues that they could also have a mild form of COVID. So we are thoughtful about making sure we evaluate with the chest x-ray and oxygen levels and really getting a good history from our patients to sort of understand, do you have a mild cough? Do you have some symptoms? Is that new or different for you? Because I think for a lot of folks, because the pandemic is so understandably scary, and there are many reports of how severe patients can, how severely ill patients can be, it's natural to sometimes not remember that the vast majority of folks who get COVID-19, it's going to be a fairly mild viral illness. And in people's interpretation, well, this is just like the cold that I've had, or this is just like the respiratory illness I get in spring. And that's how it could be. And so that doesn't mean we do anything different. But in the hospital, if you're coming in, we want to be thoughtful about it so that we can test and make sure that we ensure there's no risk of spread to other folks. Yeah, that's why the social distancing is so important.
That's what I was just going to say. I think social distancing has probably, it's obviously helped us out tremendously. We were planning for many, many more admissions and many more sick patients that we were going to be taking care of in the hospital. And knock on wood, we fortunately have not seen that yet. And so I think through that and a very vigilant job by our emergency room physicians of testing patients in the emergency room, it's been the patients that we expect to have COVID symptoms with these low oxygen levels for the most part is what we're seeing. There's been, again, a manageable number of patients that we're seeing in the hospital with those symptoms.
That's a wonderful last word. Thank you, Dr. Justin Hopkin and Dr. Paritosh Prasad. Thank you, media folks, for joining us today. If you have follow-up questions or ideas for future media briefings, please send an email to mediainquiries@urmc.rochester.edu. I want to thank Jeff Mead, our video producer, who added a better camera and was able to do some close-ups that we hope help you folks doing TV coverage, and Corey White, who's running the Zoom for us. So thanks, everybody, very much, and we'll probably see you next week.
This is Wendy. Is there any chance I could trouble you to repeat those numbers you said right at the very beginning of the number of patients? I kind of think we might have missed that.
As of our morning briefing in Strong Memorial Hospital, this is not system-wide, 57 patients who have tested positive for COVID-19. 31 of those patients are in an intensive care unit, and 26 are in standard patient rooms, and that's the Dr. Hopkins unit that would be taking care of them, and the 31 patients in the ICU, that would be Dr. Prasad's team.
Thank you. I appreciate that.